thanks to the organizers for the opportunity to speak here today. The topic I'm presenting is diagnostic biomarkers in metastatic breast cancer, focusing on immunohistochemical markers. So these are the scenarios in which diagnostic markers are particularly useful. When a patient has an extramammary tumor with a history of breast cancer, the clinical question is this new tumor a metastasis from the breast cancer, or is it a independent secondary, a second primary? I'll just try the mouse again. Metastatic carcinoma can be the initial presentation in a patient, and there could be many possible primary sites, often including breast. The breast is also a site that could harbor metastasis, with melanoma being the most common tumor, and the most carcinomas being ovarian carcinoma, lung carcinoma, etc. And it's of clinical significance to distinguish these from primary breast cancer. And this diagram is a simplified summary of currently known immunohistochemical markers used for clinical differential diagnosis of carcinomas. The cancer types based on the organ size are in red. The relatively specific and sensitive markers are in white, and there's some that are not so sensitive and specific. Those are in parentheses. They're listed here because of lack of better markers in those organs or the types of tumor. And as you can see, this is centered around serokeratins, especially serokeratin 7 and serokeratin 20. Serokeratins are proteins of intermediate filament of the cytoplasm. It's a family of about 20 proteins. Even in the early 80s, it's been known that these are expressed mainly in epithelial cells, normal or neoplastic, and they have tissue specificity. So now serokeratin 7 and serokeratin 20 are the most extensively used ones for differential diagnosis. A common feature of all these markers is that they're not entirely specific or sensitive. For that reason, there are many caveats for this diagram, which I won't be able to discuss all of them today. I like to focus on a few markers that are specific and relatively sensitive in the breast. So most of the breast tumors, most of the breast carcinomas are positive for serokeratin 7 and negative for serokeratin 20. The majority of them are positive for ER/PR. So when you have a ER/PR positive tumor, the differential diagnosis is quite narrow. Mainly you have breast carcinoma and carcinomas of the gynecological tract, primarily ovarian carcinoma, in the differential diagnosis. However, when there is a ER-negative tumor, especially if it's triple negative, the differential diagnosis is quite broad. And that's where the tissue-specific markers are heavily relied upon for differential diagnosis. So GCDAP15 has been used as a diagnostic marker since the late 1980s, and the sensitivity in breast cancer is about 60%. Mammoglobin started as a clinical marker in about 2005, and the sensitivity is around 80%. GATA3 is a relatively new marker. Our clinical lab introduced it at the end of 2012, and the sensitivity in breast cancer is 70 to 80%. So these numbers are in breast cancer in general. The question clinically is what percent of triple-negative cancers express these markers, because these are the most useful in that setting. So in about 2012, we conducted a study to look at the expression of GCAP15 and mammoglobin in triple-negative breast cancer, and this was before the availability of GATA3. So we included 63 primary triple-negative breast cancers and 118 metastatic triple-negative breast cancers. And these were clinically established metastatic triple-negative breast cancers with or without the support by immunohistochemistry. We had two cutoffs. One is we had 0% staining as cutoff, meaning any positive staining was considered positive. And the other cutoff we defined as more than 5% of positive staining. The reason for having these two cutoffs is because clinically we do consider any positive staining as reportable, so we do not ignore any staining when we report the results. However, practically, if you have very focal staining, the interpretation can be quite difficult. As I mentioned, these markers are not entirely specific, so focal staining can be seen in tumors of other sites. As you can see, the percentages were quite low. In primary triple-negative breast cancer, GCDAP15 was expressed in 14%, even when any positive staining was considered meaningful. 25% for mammoglobin, and 30% of them were positive for at least one of the two markers. These numbers dropped a little bit when the 5% cutoff was applied. In the metastatic triple-negative tumor cohort, the numbers were slightly higher, however, they're not very different. So when GATA3 came out, we wanted to look at its expression in triple-negative breast cancer and also compare that to the expression of GCDAP15 and mammoglobin. And we did a second study, which is coming out this month. So in this newer study, we included 62 primary triple-negative breast cancers, and all these were used in the first study as well. And we had 68 metastatic triple-negative breast cancers. Some of these overlapped with the cases used in the previous study. And this is a distribution of the metastatic sites. Here is the list of the antibodies we used in the study. Again, here we used the 5% positive, defining positive as more than 5% of the tumor staining for any one of these markers, and 5% or less staining was defined as focal. This is the score sheet of the results in the primary triple-negative breast cancer cohort. So among the 62 cases, 14 were positive for GATA3, 11 were focally positive for GATA3, and 37 were negative for GATA3. And if you look at the cases that were positive for GATA3, one of them was positive for mammoglobin and GCAP15. One was positive for mammoglobin and focally positive for GCAP15. so on and so forth. So this is the summary of the results in the primary cohort. GATA3 was positive in 40% of the cases if any positive staining was considered positive. GCDP15, 15%, and hemoglobin 26%. These numbers are essentially the same as we have shown in the previous study. So if you look at the bottom line, the number of tumors that were positive for all the markers was very small, and 56% of the cases were positive for at least one of the markers. Of course, as expected, if we apply the 5% cutoff, these numbers were lower, and 31% of the cases were positive for at least one of the markers. This was a breast resection specimen with an unusual histologic growth pattern, in that the tumor cells were scattered in a few small foci in a very dense lymphoid infiltrate. So the question was, could this be a metastasis from other organ sites? This tumor was pan-cytokeratin positive, but very focally positive for cytokeratin 7. It was triple negative for GCDP15 and hemoglobin, but nicely positive for GATA3. And clinically, this was also consistent with a breast primary. This is the result in the metastatic triple negative tumor cohort, and this is pretty similar to the results in the primary cohort. GATA3 was positive in 44% of the cases. 62% of the cases were positive for at least one of the markers. Again, if 5% cutoff was applied, the number or the percentage of cases positive for at least one of the three markers was 44%. This is a case of metastatic triple negative breast cancer that is focally positive for GCDP15 and hemoglobin. Both of these have cytoplasmic staining, and diffusely positive for GATA3, which is a nuclear staining. So to summarize, GATA3 is a more sensitive marker than GCDP15 and hemoglobin in triple negative breast cancer. A panel of stains, including all of these three markers, may increase the diagnostic accuracy for tissue origin. However, if we keep in mind that about half of the cases would be negative for all these markers, the sensitivity in triple negative breast cancer is only moderate even when all three markers are combined. Therefore, negative staining for all markers does not exclude breast origin. I would like to acknowledge the co-authors on these studies, as well as people who provided technical support and administrative assistance for these studies. And thank you for your attention.